Well, hello everybody and welcome to this week's Infection Control Matters. And this week I'm at the APSIC meeting in Singapore. I bumped into my co-host, Phil Russo. Hello, Phil.
Martin, good to see you at the 10th International Conference of APSIC. So
nice
in
plug.
Singapore. Pleasure to be here.
Yeah. We thought we'd have a chat and a catch-up. And Phil's been involved with a group recently that's published on experiences of infection control professionals during COVID. So we thought we'd have a chat about that. So do you want to give us a bit of background there, Phil?
Sure. Thanks, Martin. When you contacted me and said, let's talk about that COVID paper, I did have to qualify.
Which COVID paper?
Which COVID paper? Because this one in particular feels like such a long time ago now, to be perfectly honest. It was done in 2020 and have been involved in a couple more since then, looking also at healthcare worker experiences and the effect it's had on healthcare workers. But this one in particular was done by, and I've got to give a lot of credit to Alicia Baswa, who was a medical student at Monash University, and I was one of a number of supervisors for her on this project, together with Joe Doyle, Darsh Aiton, and Andrew Stewartson. So all credit to them as well, but particularly to Alicia, who did the bulk of this work. But the idea, this was in 2020. Alicia was attached with one of the big public hospitals in Melbourne, Victoria, that was getting smashed by COVID. COVID wards kept on getting bigger. Healthcare workers kept on acquiring COVID, and they could, working closely with the IPC team there, they could see that the IPC team were getting smashed. And the questions came up that surely this has probably been experienced across Australia by all IPC teams and ID physicians. So she decided for her project that she would do a cross-sectional survey looking at the experiences of infection prevention control teams and mostly the infectious diseases physicians that were attached to those teams.
Okay, and these are teams in acute hospitals, not talking about community or other settings.
That's correct, yes, in the hospitals, yeah. So it just so happened that I was resident of APSIC at the time, and Andrew was heading up the IPC group for the Australasian Society of Infectious Diseases, which is about healthcare-associated infections. So we had good networks, and participants were recruited through the APSIC mailing list and also the ACID mailing list.
Okay. Decent response rate? Because I can imagine people are a bit under the cosh at the time. Would they think, no, not another questionnaire?
I'm sure that's what they did feel. Yeah. And it's really difficult to calculate a response rate because we don't actually know how many people got those emails.
Okay.
The databases at the time indicated that there was around about, I think it was about 12 or 1,300 APSIC members at the time, and similar for ACID members, but we don't know because it was advertised by email and also newsletters. Yeah. So we don't actually know how many saw it.
Relies on email addresses being updated, doesn't it? Yeah.
Okay. So we couldn't calculate a response rate, but we did get 160 responses all up. It was, but 146 were complete. That finished the survey.
Okay. Findings.
So interesting. There was a number of queries in the survey about their PPE, about guidelines, and about communications from government and also the hospital executives. Some of the key findings were perhaps in contrast to a lot of media at the time that talked about shortages of PPE in hospitals and nursing homes, and I'm sure some did experience that. But the responses from this group was that it wasn't so much a shortage, but what was really challenging with PPE was the broad variety of equipment that they were supplied with. Like, I remember in one particular instance, I think one hospital had 4 or 5 different types of face shields, all attached differently, all looked different, all came in different packaging. So you get used to one and then another one would come along and another one would come along. Similarly with the N95s and P2 masks.
That's the problem. In the UK, we're having to fit test every single N95. So if you had 5 different N95s in your organisation, people had to be fit tested 5 times.
That's correct.
Nightmare. Do you have to fit test in Australia?
We didn't. We do. Well, that's a big question, one, for the fit testing. I think if I look back, was around about this time that fit testing was very much on the agenda for a lot of discussion.
Okay.
Because of the very fact that, well, there was two different schools of thoughts, I guess. But I think now it's a fairly standard part of the respiratory programs in hospitals. But yeah, different types of N95s. I mean, you get fit tested for one mask, not the next brand that comes along that's slightly different. You have to get fit tested for that. But that was one of the challenges that the IPC teams found with PPE, was the different brands and models that they were supplied with.
That's an issue, isn't it? Because you can deal with what's in front of you, but if what's behind you, you don't know anything about,
yes,
you're constantly having to chop and change.
That's right. And, they all have different packaging that open them up differently. You're trying to do things quickly and efficiently, and gowns tying up slightly differently. So it just adds to that extra burden that staff...
Not great for staff either, really, trying to learn a different system every day. So that must be really frustrating all round, not only for the IPC team.
Yeah, that's right. The other broad area that we explored was in relation to guidelines, and we asked them about whether or not they had their own guidelines, what they thought about the government guidelines at the time. Australia is a little bit unusual because we're a federation, so we have a Commonwealth government, and states and territories have their own governments as well. So at that time, we had a body infection control expert group, which I was actually on at that time, I think. Yes, I was still on that, who were providing general advice to the Commonwealth government about guidelines. And then, of course, each state and territory had its own health department, and they had their own guidelines, and then hospitals have their own guidelines as well.
Does it cascade down that what the Commonwealth says?
Not necessarily.
The states do. Okay.
Remembering that they're guidelines, they're not rules, they're guidelines. And so,
back to the Pirates of the Caribbean here, aren't we? Yeah.
The Commonwealth tended to be very high level, I guess, broader, and the state and territory guidelines will probably be a little bit more prescriptive. But at the end of the day, the hospitals may have had to amend to fit their purpose. But we asked them whether or not they agreed, and there was, fairly good support that they felt that the government guidelines were supported by scientific evidence, and that, increased their acceptability, and they were sufficiently detailed to follow.
I mean, you had that fantastic evidence group, didn't you? They were constantly issuing the latest, but not a lot of that was IPC related. That was more about treatment and management of the case.
That was about the wonders of ivermectin and hydrochloroquine at that time, which was causing probably a lot of grief. But the guideline COVID-19 evidence false task base were more at that stage focused on treatment.
Okay.
But back with the guidelines, though, the issue for the infection control teams, the ID teams, was not so much what was their content, because they were generally in agreement with them, but it was how frequently they were amended and updated, and the timing of
generally. Okay. The UK system was about 5:36 on a Friday. Especially before a bank holiday weekend. That seemed to increase the chances of a new guideline.
Yes,
which is a significant issue for people. I know, looking at Twitter, it would combust every Friday evening.
And I tend to believe that I don't think that was an intent, intentionally done at that stage.
It just happened that way.
I think that was just, they would probably spend the whole week or the whole day looking into the evidence and putting drafts together and getting them signed off and that sort of stuff. And when they're all done, it just happened to be at bloody 7 p.m. on a Friday. And they felt an urgency to get them out as quickly as they could, and that's when they would get released. So it was the timing of the release of the guidelines that was causing a lot of frustration for the hospitals, and it was also the frequency of modification. And what I remember at the time, this new information was coming about what's a close contact, and okay, so this person's close contact, so now we have to furlough them for this period of time. And so there was a lot of quick changes with regards to furloughing staff and how long they had to be off for, the types of requirements, testing that they had to endure before they came back to work. So those little technicalities change on a regular basis, but they were particularly important for hospitals who were furloughing so many staff at that time.
And it's a particular problem, though, for IPC teams, because they're having to give out a new guideline all the time. So it almost makes them look like they can't make up their mind, which is a problem.
Yeah, and they would get questioned by staff. Well, yesterday you said this, but today you're saying that.
Which actually happens quite frequently in IPC anyway, but during a pandemic, that was happening.
Yeah. So that was really, really informative feedback that we got from that part of the survey. Another area that we looked at was the communication, particularly with regards to communication between the government and the hospital executive and the IPC teams. And essentially, the responses were that the communication between hospital IPCs and the executives was really good. And both ways, they felt that communication.
There was a lot of building, actually, of communication streams and mutual trust between management and IPC teams, wasn't there? I mean, certainly we felt that in the UK.
I think that in the stories, can't say that it really came through strongly in this survey, but certainly the anecdotal stories, there was a real strengthening of relationships between IPC teams and executives during this time, which is a great thing.
Oh, yeah, as long as we can sustain it.
Yes. Well, other things are being sustained at the moment, aren't they? The area where they felt the communication was worse was that between the infection control teams and the government. They felt there was a bit of a disconnect there, and that the government, the infection control teams found it hard to get the ear of the government.
I think that's echoed.
It's not surprising
around the world, and certainly in the UK that would have been echoed, that feeling, frustration.
The other two more areas that we looked at, the next one was redeployment. So as you can imagine, that during this time there was lots of staff having to be furloughed because of either having COVID or being contacts, and that required a huge amount of resources for contact tracing within the hospitals. So there was a lot of redeployment of hospital staff into the infection control team. And I think from memory at one stage, one large public hospital had around about 40 staff working on their contact tracing team. Now, these were staff that were pulled from all over the area. They weren't infection control literate, so to speak, but they were needed to help the IPC teams. But that was an issue because they did find that many of the staff who were redeployed didn't have great computer skills. And, when it comes to contact tracing and having to do things quickly, you need those sorts of broader skills. So they felt that for, future planning, for the future pandemics, that when it comes to ramping up staff, we need to actually not just pluck anybody out, but have a little bit more criteria about who's going to be helpful.
That makes sense. That's useful bit of learning. Have a minimum set of skills that might.
Yes, and I guess that just reflects the responsiveness of the action at the time. They just had to do something quickly. And finally, we asked about personal experience of the IPC teams and the ID physicians. And, not surprisingly, and I suspect that we're going to hear about this for a long, long time as the mental health issues will sort of manifest over the next few years, I guess. But the IPC teams, reported a significant increase in workload, which is no surprise. They felt as though they weren't doing their job properly because all their routine infection control activities had to be pushed to the side. And so they really felt as though they weren't aware of what was going on in other areas of infection prevention because all their focus was on COVID. And that this, obviously 48% reported that they felt as if they were very burnt out. I suspect now if we were to repeat that survey, it would be much higher. This is 2 years ago.
I'm a bit surprised it was only 48, to be honest. That shows a degree of resilience amongst the IPC teams. You said you've been doing a bit of work since. Can you give us a flavour of what may come?
I'm part of what is called the COVIC-HA study, which is a Victorian study, which is a multi-centred study, and it's a longitudinal study. So being headed up by Monash University in Cairnleader. It's been funded by the state government. And so we've followed a cohort of healthcare workers over a 2-year period and done repeated surveys of them. And we're just starting to get some data back now, which is, I guess, concerning from the point of view of how it's affecting healthcare workers. This is not just infection control staff. This is all healthcare workers and includes some ambulance staff as well. But the first lot of findings are being written up at the moment, and it's quite startling what we're seeing, I think, and I think it'll be very, interesting for some people to read how that's been. But that they are due for another survey. There's going to be 3 surveys, and so I think it's a cohort of several thousand.
Oh wow!
So
okay.
it's quite a
so this is survey or interview?
Both.
Okay.
So there's a survey aspect to it, and also an interview aspect as well.
Okay, big piece of work.
It is a big piece of work, and it's I'm lucky to be part of it with many other people. That's the COVID HA study, which there is a website if you wanted to have a look at it.
Okay,
there'll be more publications coming out soon.
Yeah. Okay.
Yeah.
Okay. Anything else? Do you think?
Well, it actually just reminded me of I came across a paper that was just released a couple of days ago, and so this was a study that was done by researchers at Deakin University in Victoria, and it looked at the impact of COVID-19 on nurse alcohol consumption.
We're not talking hand rub here, I'm
We're not talking hand rub here. And it's a qualitative study. They did 42 interviews, semi-structured interviews with nurses over several months in 2021. And, I'll encourage people to go and put this a link to this paper, but there's a significant amount of increased alcohol consumption amongst nurses.
Okay. Not just IPC teams, but
nurses, yeah. And, for a number of reasons, but there's a lot of expression of feeling exhausted, overworked, burnt out, cut.
There's a lot of warning signs there, aren't there, for future workforce planning?
Yeah. So, this is 42 is probably you would consider a small sample, but it is a qualitative study, and some of the findings and some of the commentary that we get from those nurses who are interviewed is quite revealing. So I'd encourage people to go and have a look at that. That was from the Journal of Clinical Nursing, and I added a CV.
Okay. Yeah. Right, Phil, great to see you again.
Thanks very much. Good to see you.
Yeah. I'm looking forward to the other work from the big study that you're involved in, but I think similar studies conducted around the world, I think will be likely to show the same sort of findings for you. The PPE anxiety, I had a little bit of that myself when I worked a little bit in the front line, but also the constant barrage of change of guidance was coming to everybody. But I'm never convinced that it has to come out at 5:30 on a Friday evening, unless there's such a big change that you then can't send it out on a Monday morning and then set it forward. If it's going to have that big an impact, because the stress levels actually went up quite markedly amongst colleagues I know from talking to them on a Friday evening, the frustration, and then they either stay there and work over the weekend when they're already had it.
Yeah.
And I'm not sure that that's the best way to do it, to be honest. And just saying something will be out every Monday morning at 9 o'clock, you're ready for it, you're prepared, and you're ready to go. Unless it's that urgent, I'm not convinced.
My what I believe is happening is they're risk averse.
Yeah.
If they held on to it till Monday and somebody said, you knew about this all weekend and you didn't tell us to change this guideline, that's negligence.
Yeah, but they knew about it on the Wednesday and it was just going through sign-off until Friday.
That's right.
So you can get the same argument.
Yeah.
It's if it's that urgent, get it out quick. But okay. Well, thanks very much. Great to see you again.
Thanks, man.
Who knows where and when?
Next time.
Yeah. And we'll catch everybody again on the next episode of Infection Control Matters.